Good morning, class. So today we are going to talk about our case presentation on MaryAnne Nguyen,
And my name is Angelica Garcia.
and my name is Mark Guerrero.
So currently I am doing my field placement at Fresno State at the Student Health and Counseling Center, and I am on the counseling side. So uh, it is called Counseling and Psychological Services, also known as CAPS. CAPS offers a safe place for students to express their thoughts, feelings, and concerns. Uh, we are located on the south side of campus in the single-story red brick building between the dorms and the lab school. So most likely you have all seen it. The Student Health Center is supported by the mandatory health fee that is paid by each student as part of their Fresno State tuition. And the mission statement at CAPS is to promote the academic and personal success of Fresno State students by encouraging the maintenance of healthy lifestyles and providing affordable and accessible health and psychological care.
So the services provided at the Student Health and Counseling Center, um, there are individual and relationship counseling. They have group counseling, psychiatry, case management services, and suicide prevention. Getting started, students call the number to schedule an appointment. So for the initial appointment, the students should arrive 20 minutes ahead of their scheduled appointment to complete a brief questionnaire. They meet with the counselor to help them create a treatment plan that matches their needs. And then over the course of their meetings, they put their plan into action.
So if you have been to the Student Health Center, you most likely have been instructed to go to the iPads that are on the right side as you enter, and you most likely have taken a patient health questionnaire, which is the GAT-7. It is a sensitive self-administered test to assess generalized anxiety disorder. And then the PHQ-9, which is a multi-purpose instrument for screening, diagnosing, monitoring, and measuring the severity of depression. So like Mark said, on your first appointment, you do have to arrive 20 minutes before your initial consultation. And this is where you are directed to take the Celeste Health BHM-20. And this is a 20-item client report questionnaire that assesses the three phases of behavioral health. So one being well-being, which measures the stress, life satisfaction, motivation. Two, psychological symptoms such as depression, anxiety, panic disorder, alcohol, drug abuse, suicidal ideation, and risk of violence. And third, life functioning, which is work, school, intimate relationships, social relationships, and life enjoyment. And then there's also the CAPS personal family history form.
So our patient in particular, MaryAnne Nguyen, her initial consultation was on 10/19/19. Her age is 18. She is a female. Ethnicity, Vietnamese. Her sexual identity, she identified as bisexual. Her religious affiliation was Catholic, and she's currently holding 12 units this semester. Major it was in biology, and it was a self-referral. Was she employed or volunteering at the time? She was not. She did not disclose any serious medical conditions, and she currently lives with her mother, father, and 15-year-old brother.
I do want to add that those responses were provided by her herself, and the counselor does obtain this information as soon as she finishes answering these questionnaires. So 5 minutes before their appointment, the patient should be finished with the questionnaires. Therefore, we are given about 5 minutes to quickly review her answers and therefore give us an idea of what we will be facing with as the client comes in. So now we're going to be discussing the patient's upbringing and family background. So the patient denied any family history of mental illness, drug abuse, or concerning medical conditions. She did share that her parents are immigrants from Vietnam. She is a firstborn child and only has one brother who is 15 years old. Her mom has her own dental practice. Her dad is a pharmacist. The patient described her mom as a breadwinner and the more authoritative parent. They do attend church every Sunday as a family. As a child, she was terrified of the consequences of bringing home a test with a grade below a 90%. Her parents engaged in corporal punishment as a child. So if she were to come home with a paper that was less than 90%, they would engage in that corporal punishment. If she did not follow strict rules, they would engage in corporal punishment. She did graduate from a small charter high school that emphasized college prep academics. The majority of her extended family members are in the medical field, and she has been pressured to major in biology and follow family footsteps.
So now the mental status exam. So the physical appearance, she appeared well nourished and well appearing. Orientated to person, yes. Place, yes. Time and situation, also yes. Relatedness, she was engaged. Her eye contact was good. Attitude, she was very cooperative. Motor behavior was normal. Affect, she was congruent and tearful. Mood, neutral and sad. Her speech was reported as normal. Thought process, normal. Thought content, unremarkable. Insight, good. Judgment, good. Memory, intact. Attention, concentration, intact. Intelligence, average. Impulse control, normal. And violent material, not assessed at that time.
And the counselors are prompted to engage in a mental status exam at every visit. So every time a client goes in for an appointment, we are to construct this MSE. So here are some of the presenting problems. The patient is seeking services at the Student Health Center to learn coping skills and feel good about herself. This is what she reported to me on her very first visit. She has frequent conflict with mom and poor communication with both parents. This has increased in the last year. The patient feels unloved and unsupportive, wants to major in art, but received negative feedback from parents. So she does not want to major in biology. She's not interested. She has no passion. She does not want to major in that. And so she has a passion for art, and she was able to express this to mom and dad, stating that she wants to major in art. And initially, mom was very supportive about it. However, a couple of days later, the mom approached her and was crying and stating that if she chooses to major in art, she will end up homeless. So these are the words she heard from her parents, that if she chooses to major in art, she will have a bad life and they will not help her out. Also, the patient has to be home by 6:30 p.m. She's not allowed to attend art or music shows and is highly encouraged to obtain a 4.0. She has difficulty adjusting. She has been having difficulty adjusting from her small charter school to the university. She describes isolating in her bedroom in order to avoid conflict and reports feeling increasingly depressed. When conflict does arise, she minimizes the importance of the issue and withdraws from the offending individual. She has difficulty expressing her thoughts and needs and feelings to others. Her relationship with her parents and brother are important to her. However, she admits to hiding information, such as, her attending counseling, her sexual identity, and her thoughts in regards to their parenting style. She compares herself to her sibling a lot and feels that she does not live up to her potential within her family. She has reported difficulty getting out of bed in the morning and does not have the motivation to attend class, and reported having difficulty concentrating. She described feeling socially tired, but expressed a desire to make connection with peers. She reports feeling lonely and misunderstood by others. She has feelings of guilt and shame for being bisexual. They are Catholic, so this is viewed as a sin. She fears being viewed as a banana in her culture, and this term I wasn't aware of it, and she was able to inform me on it. So banana is basically like a pejorative for ethnic East Asians or Southeast Asian people who are considered to have abandoned their Asian culture identity or lost touch with it in order to adapt a Western culture identity. Okay, so her coping skills at the time of the initial consultation were taking space, which in other words was isolating, and cutting. She engages in self-harm 2 to 3 times a month, and this has been occurring since 7th grade, but it's on and off, and she reported frequent urges to engage in self-harm.
So self-harm signs and symptoms. Type of self-harm behaviors, cutting, frequency, on and off 2 to 3 times per month. Severity, the patient reported minor wound, 2 to 3 cuts per engagement with a pencil sharpener blade. Duration since the 7th grade. Reason for behavior, coping mechanism. No others aware of self-harm behavior. No medical attention needed for treatment of self-inflicted wounds at this time.
So these are the diagnoses for this patient. Major depressive disorder, recurrent episode moderate, as evidenced by feelings of worthlessness, sadness, hopelessness, lack of motivation, insomnia, fatigue, tearful, low self-esteem, lack of social connections, and difficulty concentrating. Z codes are personal history of self-harm, as evidenced by intentional self-inflicted damage to the surface of the body with expectation of physical harm, but without suicidal intent. So she did denied suicidal intent. Patient interest to seek relief from negative thoughts or feelings. Another Z code is parent-child relational problem, as evidenced by constant or frequent conflict with parent, long period of poor communication with parent, and she describes herself as a black sheep in the family.
So the theory we utilized was a systems theory first. The focus of systems theory states that behavior is influenced by a variety of factors that work together as a system. A person's parents, friends, school, economic class, home environment, and problems affecting them, such as depression, low self-esteem, and relationship problems. These factors all influence how a person thinks and acts. Applied. Using social systems theories helps the counselor look beyond the patient to understand factors at multiple levels of the patient's social systems that may be contributing to her struggles. Social systems approaches empower the counselor to address changes at multiple levels of the patient's social environment, seeking to help correct missing or ineffective parts of that system can have a positive impact on behavior. So an aspect of systems theory is Bronfenbrenner's social ecological model of development. The social ecological model of development is another specific social work practice theory based on social systems thinking. This model looks at how multiple systems and levels of social environments, like the individual, micro, meso, exo, and macro systems, impact individuals' experiences and behavior.
Okay, in terms of another theory, we use relational cultural theory, and the focus of this theory is on human connections and the way culture influences relationships. This theory proposes that all human beings grow in and toward relationships throughout their lives, and the outcome of healthy development is a desire for better or more connections. So RCT takes into account social factors such as race, class, culture, and gender, while offering a paradigm to support client growth. People who are experiencing distress from their family, intimate, professional, or social relationships may benefit from this theory. RCT influences how counselors conceptualize client issues. It establishes a direction for the counselor-patient relationship. So this is how it is applied. In relational therapy, the patient learns to identify how she may be pushing people away rather than attracting them, and also comes to understand how these behaviors are related to past experiences. A counselor works towards helping the patient conceptualize herself with a broader context, one that moves them out of a position of shame and defectiveness and isolation and more towards genuine authenticity and connection with others. Mutual empathy and a growth fostering counselor-patient relationship provides the ability for change. So the aim is to develop new ideas about relationships, to build a strong relationship with the counselor, and to use both those new ideas and the therapeutic relationship as a model to create healthier, longer lasting relationship with others.
So treatment plan and treatment goals. So the treatment plan was ongoing individual treatment recommended, and the patient agreed. Patient will receive counseling services 2 times per month. The goals for treatment. Throughout the semester, the patient will attend 1 or 2 PER groups and RIO group in order to heighten awareness and provide a sense of support. Patient will attend 1 or 2 appointments at the Student Involvement Center to learn about clubs and volunteer opportunities in order to increase her social. Patients will develop healthy cognitive patterns and beliefs about self that lead to alleviation of depressed symptoms. Patient will also be encouraged to describe how it was to grow up in her home and her relationship with all immediate family members. So the goal of the treatment, throughout the semester, patient will implement journaling 3 to 4 times a week, where she will express her feelings and gratitude of the day in order to bring more self-awareness of her feelings and thoughts. Patient will also develop and implement 3 to 4 alternatives for self-harm. So far, 2 alternatives that have been working for her are rubber band wrist smacking. So she puts a rubber band on her wrist, and whenever she feels like she wants to cut, she smacks her wrist with the rubber band. And the second being whenever she feels like she wants to self-harm, she instead writes little notes to herself, on her body, or draws on herself. So yeah, and she engages in this alternative uh, whenever she feels like cutting. And recently added, actually, the patient will create a daily schedule, include regular wake time and bedtime, classes, study time, self-care, like social time via phone or Zoom, brief time in the sunlight, only when social distancing is possible, gratitude practice, safe space imagery, drawing, use any of these strategies at least once per day.
So this is a oh. So this is a timeline, a self-harm timeline. So when she first came in October, she reported engaging in self-harm 2 to 3 times a month. In December, she reported self-harm behaviors 2 times in the last month. In January, she reported 1 time. In February, she reported 1 time. And in March, she reported no self behaviors. I do see her again later this week, so I'll get an update then whether or not she has been able to maintain the ability to refrain from these self-harm behaviors.
So conclusions. The patient has self-reported a decrease in presenting depression symptoms, improvement in experience of parent-child relationship as evidenced by patient's self-reporting, reduction in self-harming behaviors, and has maintained ability to redirect urges as reported by the patient. Patient will be prompted to retake the Celeste Health BHM-20 prior to termination to measure improvements and will be used as an evaluation tool for a counselor.
Yeah. So we have 2 engagement questions. One being, do you agree with the diagnosis and corresponding Z codes used in this case? Why or why not?
And our second question is, I feel relatable to many of our internships at this time. So it reads as, what are your thoughts on using services like Zoom to meet with clients or patients during these social distancing times? Is it beneficial or detrimental to the client's overall success? Let us know what you think, and thank you.
Thank you.